the use of anti-D immunoglobulin for the prevention of hemolytic disease of the fetus and newborn. Introduction. Prior to the availability of anti-D immunoglobulin or anti-D-Ig, the incidence of RHD alloimmunization in D-negative women following 2 deliveries of D-positive, ABO-compatible infants was approximately 16%, and hemolytic disease of the fetus and newborn, or HDN, due to anti-D was a significant cause of morbidity and mortality. Following routine postpartum administration of anti-D-Ig, the rate of alloimmunization dropped to approximately 2%. A further reduction in the sensitization rate, ranging from 0.17 to 0.28%, was achieved by introducing routine antenatal prophylaxis during the 3rd trimester of pregnancy. Associated with this reduction in sensitization is a reduction in mortality associated with hemolytic disease of the fetus and newborn from 46 over 100,000 births to 1.6 over 100,000 births. Potentially sensitizing events requiring anti-D immunoglobulin prophylaxis. Pregnant D-negative women with no immune anti-D should be offered prophylactic anti-D immunoglobulin for potentially sensitizing events listed in Table Number 1. A dose of anti-D immunoglobulin appropriate to the gestation should be administered within 72 hours of a potentially sensitizing event. However, if exceptionally this deadline cannot be met, some protection may still be offered if anti-D immunoglobulin is given up to 10 days after the sensitizing event. Table number 1. Potentially sensitizing events in pregnancy. Amniocentesis, chorionic villus biopsy and chordocentesis, antepartum hemorrhage or uterine PV bleeding in pregnancy, external cephalic version, abdominal trauma, sharp or blunt, open or closed, ectopic pregnancy, evacuation of molar pregnancy, intrauterine death and stillbirth, in utero therapeutic interventions such as transfusion, surgery, insertion of shunts and laser, miscarriage or threatened miscarriage, therapeutic termination of pregnancy, delivery, normal, instrumental, or cesarean section, and intraoperative cell salvage. Potentially sensitizing events in pregnancies of less than 12 weeks of gestation. Laboratory tests required. A maternal blood group and antibody screen should be performed to determine or confirm the RHD group and check for the presence of immune anti-D. Women with anomalous RHD typing results should be treated as D negative until confirmatory testing is completed. A test for fetal-maternal hemorrhage or FMH is not required. Administration of anti-D immunoglobulin. In cases of spontaneous complete miscarriage confirmed by scan, where the uterus is not instrumented, or where mild painless vaginal or PV bleeding occurs before 12 weeks, prophylactic anti-D immunoglobulin is not necessary because the risk of fetal-maternal hemorrhage and hence maternal exposure to the D antigen is negligible. In cases of therapeutic termination of pregnancy, whether by surgical or medical methods, and regardless of gestational age, previously non-sensitized D-negative women should receive a minimum dose of 250 international units prophylactic anti-D immunoglobulin within 72 hours of the event. There is a significant potential for sensitization in cases of ectopic pregnancy. A minimum dose of 250 international units anti-D immunoglobulin should be administered to all cases of ectopic pregnancy in previously non-sensitized D-negative women regardless of the mode of management. The authors feel that this has potential for causing confusion resulting from inconsistency with established current practice based upon RCOG Green Top and BCSH guidelines and introduces complexity into decision making without strong evidence to support any such change. There is significant potential for sensitization in cases of molar pregnancy. A minimum dose of 250 international units of anti-D immunoglobulin should be administered to all cases of molar pregnancy in previously non-sensitized D-negative women. Evidence that women are sensitized after uterine bleeding in the first 12 weeks of pregnancy, where the fetus is viable and the pregnancy continues, is scant. Therefore, anti-D immunoglobulin is not necessary in women with threatened miscarriage with a viable fetus where bleeding completely stops before 12 weeks gestation. However, 250 international units anti-D immunoglobulin should be administered where bleeding is heavy or repeated or where there is associated abdominal pain, particularly if these events occur as gestation approaches 12 weeks. Gestational age should be confirmed by ultrasound. In pregnancies less than 12 weeks gestation, anti-D immunoglobulin prophylaxis, minimum dose 250 international units, is only indicated following an ectopic pregnancy, molar pregnancy, therapeutic termination of pregnancy, and in some cases of uterine bleeding where this is repeated, heavy, or associated with abdominal pain. A test for fetal-maternal hemorrhage is not required. Potentially sensitizing events in pregnancies of 12 weeks to less than 20 weeks of gestation. Laboratory tests required. A maternal blood group and antibody screen should be performed to determine or confirm the RHD group and check for the presence of anti-D. If anti-D is identified, further history should be obtained and investigation undertaken to determine whether this is immune or passive as a result of previous injection of anti-D immunoglobulin. If no clear conclusion can be reached as to the origin of the anti-D detected, then the woman should continue to be offered anti-D prophylaxis on the assumption that it may be passive. Women with indeterminate RHD typing results should be treated as D negative until confirmatory testing is completed. A test for fetal-maternal hemorrhage is not required before 20 weeks gestation. Administration of anti-D immunoglobulin. For any potentially sensitizing event listed in table number 1, confirm D negative, previously non-sensitized, women should receive a minimum dose of 250 international units of anti-D immunoglobulin within 72 hours of the event. D-negative women presenting with continual uterine bleeding between 12 and 20 weeks gestation should be given at least 250 international units of anti-D immunoglobulin at a minimum of 6 weekly intervals. For potentially sensitizing events between 12 and 20 weeks gestation, a minimum dose of 250 IU should be administered within 72 hours of the event. A test for fetal-maternal hemorrhage is not required. Potentially sensitizing events in pregnancies of 20 weeks of gestation to term. Laboratory tests required. A maternal blood group and antibody screen should be performed to determine or confirm the RHD group and check for the presence of immune anti-D. If anti-D is identified, further history should be obtained and investigation undertaken to determine whether this is immune or passive as a result of previous injection of anti-D immunoglobulin. If no clear conclusion can be reached as to the origin of the anti-D detected, then the woman should continue to be offered anti-D immunoglobulin prophylaxis on the assumption that it may be passive. Women with anomalous or indeterminate RHD typing results should be treated as D negative until confirmatory testing is completed. A fetal-maternal hemorrhage test is required to detect fetal cells in the maternal circulation and, if present, to estimate the volume of fetal-maternal hemorrhage to allow calculation of additional anti-D doses required to clear the fetal cells. If fetal-maternal hemorrhage of more than 4 milliliters is detected, follow-up samples are required at 48 hours following an intravenous or IV dose of anti-D or 72 hours following an intramuscular or IM dose to check for clearance of fetal cells. Administration of anti-D immunoglobulin. For any potentially sensitizing event, D negative, previously non-sensitized, women should receive a minimum dose of 500 international units of anti-D immunoglobulin within 72 hours of the event. A minimum of 500 international units of anti-D immunoglobulin should be administered within 72 hours for any potentially sensitizing events, regardless of whether the woman has already received routine antenatal anti-D prophylaxis or RAADP at 28 weeks. Additional dose or doses of anti-D immunoglobulin will be necessary if the volume of fetal-maternal hemorrhage exceeds that covered by the standard anti-D immunoglobulin dose in use. A follow-up blood sample should be taken at 48 hours following each IV dose of anti-D and 72 hours following each IM dose of anti-D to check if fetal cells have cleared. In the event of continual uterine bleeding, which is clinically judged to represent the same sensitizing event, with no features suggestive of a new presentation, or a significant change in the pattern or severity of bleeding, such as the presence of abdominal pain or another clinical presentation, a minimum dose of 500 international units of anti-D immunoglobulin should be given at 6 weekly intervals. In the event of further intermittent uterine bleeding, estimation of fetal-maternal hemorrhage should be carried out at 2 weekly intervals. In this situation, non-invasive fetal RHD typing using maternal plasma could be considered to reduce hospital attendance, blood sampling, and avoid repeated administration of doses of anti-D, balanced against a small risk of false negativity of 0.08 to 0.16% of fetal D typing by this technique. If the 2 weekly fetal-maternal hemorrhage test shows the presence of fetal cells, additional anti-D immunoglobulin should be administered to cover the volume of fetal-maternal hemorrhage. The additional dose should be calculated as 125 international units if administered intramuscular or 100 international units if administered intravenous for each milliliters of fetal red cells detected, a minimum of 500 international units. The additional dose should be offered regardless of the presence or absence of passive anti-D in maternal plasma, and fetal-maternal hemorrhage should be retested after 48 hours if anti-D immunoglobulin has been given IV or 72 hours if given IM. If new symptoms develop suggestive of a sensitizing event, in addition to continual uterine bleeding, for example, abdominal pain associated with a significant change in the pattern or severity of bleeding, then it should be managed as an additional sensitizing event with an appropriate additional dose of anti-D and estimation of fetal-maternal hemorrhage. Each new sensitizing event should be managed with an appropriate additional dose of anti-D immunoglobulin regardless of the timing or dose of anti-D immunoglobulin administered for a previous event. For potentially sensitizing events after 20 weeks gestation, a minimum anti-D immunoglobulin dose of 500 IU should be administered within 72 hours of the event. Appropriate tests for fetal-maternal hemorrhage should be carried out for all D-negative, previously non-sensitized, pregnant women who have had a potentially sensitizing event after 20 weeks of gestation, and additional dose or doses of anti-D immunoglobulin should be administered as necessary. Routine antenatal anti-D prophylaxis or RAADP. Laboratory tests required. A sample should be taken for the routine antenatal 28-week blood group and antibody screen as described in the British Committee for Standards in Hematology guidelines for blood group and red cell antibody testing in pregnancy before routine antenatal anti-D prophylaxis is given. If anti-D is identified in the sample, further investigation should be undertaken to determine whether this is immune or passive, for example, previous administration of anti-D immunoglobulin. If no clear conclusion can be reached as to the origin of the anti-D detected, then the woman should continue to be offered anti-D immunoglobulin prophylaxis and should continue to be monitored monthly until 28 weeks gestation and fortnightly thereafter. Administration of routine antenatal anti-D immunoglobulin prophylaxis. There is good evidence that antenatal anti-D immunoglobulin prophylaxis using either a single large dose at 28 weeks gestation or two doses given at around 28 and 34 weeks respectively achieves a significant reduction in the incidence of maternal sensitization to D. The National Institute for Health and Care Excellence Guidelines of 2008 recommend that the preparation with the lowest associated cost should be used. If using the two-dose regimen, a minimum dose of anti-D immunoglobulin 500 international units is recommended at 28 and 34 weeks. Alternatively, a single dose of anti-D immunoglobulin 1,500 international units should be administered between 28 and 30 weeks. The single-dose regimen may be more cost-effective, potentially enabling better compliance and providing logistic benefits. Use of routine antenatal anti-D immunoglobulin prophylaxis should not be affected by previous anti-D immunoglobulin prophylaxis administered for a sensitizing event earlier in the same pregnancy. All D-negative pregnant women who have not been previously sensitized should be offered routine antenatal prophylaxis with anti-D immunoglobulin or RAADP either with a single-dose regimen given around 28 weeks or a two-dose regimen given at around 28 and 34 weeks. It is important that the 28-week sample for blood group and antibody screen is taken prior to the first routine prophylactic anti-D immunoglobulin injection being given. This forms the second screen required in pregnancy as stated in the BCSH guidelines for blood grouping and red cell antibody testing during pregnancy. The routine antenatal anti-D immunoglobulin prophylaxis or RAADP scheme should be regarded as supplementary to any anti-D immunoglobulin administered for sensitizing episodes listed in table number 1. Management of routine antenatal anti-D prophylaxis scheme. Information regarding the administration of routine antenatal anti-D prophylaxis must reach the transfusion laboratory promptly, so this is available should a pregnant woman require pre-transfusion testing. This is essential because if anti-D is detected, a record of anti-D immunoglobulin administration will help in the process of determining whether this is immune or passive, and the outcome of which will influence management of the pregnancy. Identification of women eligible for routine antenatal anti-D prophylaxis involves training and regular retraining of personnel responsible. This training must be carried out to ensure that all eligible women are correctly identified and their informed consent obtained. Information leaflets should be made available to pregnant women to help with the informed consent process. Prophylaxis following birth of an D-positive child or intrauterine death. Laboratory tests required. Following birth, a cord blood sample should be tested to obtain the ABO and RHD type of the baby. If a cord blood sample is not collected for any reason, a heel prick sample from the baby should be obtained as soon as possible. Anomalous or indeterminate cord RHD groups should be treated as D positive until confirmatory testing is completed. If a sample cannot be obtained, the baby should be assumed to be D positive for the purpose of administration of anti-D immunoglobulin. A direct anti-D globulin test or DAT on the cord blood sample is not routinely performed since it may be positive in a proportion of cases because of antenatal prophylaxis with anti-D immunoglobulin. However, a direct anti-D globulin test or DAT should be performed if hemolytic disease of the newborn is suspected or anticipated because of a low cord blood hemoglobin concentration and or the presence of maternal immune red cell antibodies. Maternal samples for confirmatory ABO and RHD type and fetal-maternal hemorrhage testing should be collected after sufficient time has elapsed for any fetal-maternal hemorrhage to be dispersed in the maternal circulation. A period of 30 to 45 minutes is considered adequate, and the samples should ideally be taken within 2 hours of delivery, primarily to ensure that the sample is taken prior to woman's discharge from the hospital. Fetal-maternal hemorrhage testing should be undertaken on all D-negative women delivering D-positive infants to determine if additional doses of anti-D immunoglobulin are required. If an fetal-maternal hemorrhage of greater than 4 milliliters is detected, follow-up samples are required at 48 hours following an IV dose of anti-D or 72 hours following an IM dose to check for the clearance of fetal cells. Administration of anti-D immunoglobulin. If the baby's blood group is D positive, a minimum of 500 international units anti-D immunoglobulin should be administered to previously non-sensitized D-negative women within 72 hours of the delivery. Administration of postpartum anti-D immunoglobulin prophylaxis should not be affected by previous routine antenatal anti-D immunoglobulin prophylaxis or by antenatal anti-D immunoglobulin given for a potentially sensitizing event. A dose of 500 international units IM is considered sufficient to treat a fetal-maternal hemorrhage of up to 4 milliliters fetal red cells. Where it is necessary to give additional doses of anti-D immunoglobulin as guided by test for fetal-maternal hemorrhage, the dose calculation is traditionally based on 125 international units of anti-D immunoglobulin per milliliters of fetal red cells for IM administration. In cases of large fetal-maternal hemorrhage, and particularly if fetal-maternal hemorrhage is in excess of 100 milliliters, a suitable preparation of IV anti-D immunoglobulin should be considered. Preparations licensed for IM injection only must never be given IV. When intraoperative cell salvage or ICS is used for cesarean section, reinfused blood may contain fetal red cells. The volume of fetal red cells in reinfused blood varies from 1 to 20 milliliters. Since the volume of fetal red cells in intraoperative cell salvage blood is variable and can be relatively large, it is recommended that a minimum anti-D immunoglobulin dose of 1,500 international units be administered after reinfusion of salvage red cells if the cord blood group is D positive or if the cord group cannot be established for whatever reason. Maternal samples should be taken for estimation of fetal-maternal hemorrhage 30 to 45 minutes after the reinfusion of salvage red cells and additional dose or doses of anti-D administered if necessary and appropriate follow-up fetal-maternal hemorrhage testing performed. It is important that clinicians inform the transfusion laboratory if intraoperative cell salvage has been used to ensure that correct dose of anti-D immunoglobulin is issued. Following birth, ABO and RHD typing should be performed on cord blood sample, and if the baby is confirmed to be D positive, all D negative, previously non-sensitized, women should receive at least 500 IU of anti-D immunoglobulin within 72 hours following delivery. Maternal samples should be tested for fetal-maternal hemorrhage and additional dose or doses given as guided by fetal-maternal hemorrhage tests. If there is an intrauterine death or IUD, and hence no sample can be obtained from the baby, prophylactic anti-D immunoglobulin should be administered to D-negative, previously non-sensitized women. A minimum of 500 IU of anti-D immunoglobulin should be administered within 72 hours following the diagnosis of IUD or intrauterine death. Maternal samples should be tested for fetal-maternal hemorrhage and additional dose or doses given as guided by FMH tests. It should be noted that the diagnosis of IUD is a sensitizing event rather than delivery, and hence anti-D immunoglobulin should be administered within 72 hours of diagnosis. If cord blood sample cannot be obtained, or if cord blood group cannot be established for any reason, at least 500 IU anti-D immunoglobulin should be administered to D-negative, previously non-sensitized women. Where intraoperative cell salvage or ICS is used during cesarean section in D-negative, previously non-sensitized women, and where cord blood group is confirmed as D-positive or unknown, a minimum dose of 1,500 IU anti-D immunoglobulin should be administered following the reinfusion of salvaged red cells, and a maternal sample should be taken for estimation of FMH 30 to 45 minutes after reinfusion in case more anti-D immunoglobulin is indicated. It is important that clinicians inform the transfusion laboratory if ICS has been used to ensure that correct dose of anti-D immunoglobulin is issued. Management of transfusion of D-positive blood components to D-negative girls or women of childbearing potential. D-positive platelet transfusions. Whenever possible, D-negative platelets should be transfused to D-negative girls or women of childbearing potential who need a platelet transfusion. Occasionally, if the appropriate product is not available or its availability would cause unacceptable delay, it may be necessary to transfuse D-positive platelets. In these circumstances, prophylaxis against possible sensitization to the D antigen by red cells contaminating the platelet product should be given. A dose of 250 international units anti-D immunoglobulin should be sufficient to cover up to 5 adult therapeutic doses of D-positive platelets given within a 6-week period. In severely thrombocytopenic patients with platelet count of less than or equal to 30 multiplied by 10 to the 9th power per liters, anti-D immunoglobulin should be given subcutaneously or intravenous if preparation suitable or intravenous route is available to avoid the risk of intramuscular bleed following intramuscular injection. It is not necessary to administer anti-D immunoglobulin to D-negative females without childbearing potential or males who receive D positive platelets. Inadvertent transfusion of D positive blood to D negative women of childbearing potential. When less than 15 milliliters have been transfused, the appropriate dose of IM anti-D immunoglobulin may be given. Inadvertent transfusion of D positive blood to D negative women of childbearing potential. When less than 15 milliliters have been transfused, the appropriate dose of IM anti-D immunoglobulin may be given. When more than 15 milliliters have been transfused, it is preferable to use the larger anti-D immunoglobulin preparation equivalent to 1,500 or 2,500 international units. However, intravenous anti-D immunoglobulin is the preparation of choice, achieving adequate plasma levels immediately. Intramuscular-only preparations of anti-D immunoglobulin must not be given IV. The quantitation of D positive red cells should be performed by flow cytometry after 48 hours if an IV dose of anti-D has been given, or 72 hours if an IM dose has been given, and further anti-D immunoglobulin given until there are no detectable D positive red cells in circulation. When more than 1 unit of D positive blood has been transfused, a red cell exchange transfusion should be considered to reduce the load of D positive red cells in the circulation and the dose of anti-D immunoglobulin required to prevent immunization. In this situation, advice should be sought from a specialist in transfusion medicine, and the patient should be counseled regarding the implications of both non-intervention for future pregnancies and of treatment, including any hazards from receiving donated blood, the exchange procedure itself, and of larger doses of anti-D immunoglobulin, including intravenous anti-D immunoglobulin. A single blood volume red cell exchange transfusion will achieve a 65 to 70% reduction in D positive red cells. A double volume exchange will achieve an 85 to 90% reduction. Shortly after the exchange transfusion, the residual volume of D positive red cells should be estimated using flow cytometry. Passive anti-D immunoglobulin given in large doses may remain detectable, and tests for immune anti-D may not be conclusive for several months. Future developments, including the role of cell-free fetal DNA testing. 40% of D-negative women who are carrying a D-negative child will be given routine prophylactic anti-D immunoglobulin unnecessarily. In recent years, advancement in fetal blood group genotyping using cell-free fetal DNA from maternal blood samples taken at 16 to 20 weeks gestation have made it possible to determine fetal D type with a diagnostic accuracy of around 96%. The risk of a false negative result, that is, missing a D positive fetal blood group, by this technique is small and currently estimated to be around 0.08 to 0.16%. Principles, safety, availability, dosage, and administration of anti-D immunoglobulin. Safety of anti-D immunoglobulin. Polyclonal anti-D immunoglobulin used in the UK is prepared from pooled plasma from non-UK blood donors who have high levels of anti-D immunoglobulin either due to previous sensitization or intentional immunization. Plasma is screened for hepatitis B surface antigen, anti-HIV, and hepatitis C virus RNA. There is no evidence to suggest that anti-D immunoglobulin administered to women during pregnancy is harmful to the fetus. Allergic reactions are very rare, but severe hypersensitivity, including anaphylaxis, may occur. Anti-D preparations may contain trace amount of immunoglobulin A less than 5 micrograms milliliters -1, and hence patients with known antibodies to immunoglobulin A have a greater risk of developing potentially severe hypersensitivity and anaphylactic reactions. If symptoms of allergic or early signs of hypersensitivity reactions, including generalized urticaria, tightness of the chest, wheezing, hypotension, and anaphylaxis develop, administration of anti-D must be discontinued immediately and appropriate treatment instituted. Preparations available in the UK, dosage, and route of administration of anti-D immunoglobulin. 1 microgram of anti-D immunoglobulin is equivalent of 5 international units. A dose of 500 international units intramuscular is considered sufficient to treat a fetal-maternal hemorrhage of up to 4 milliliters of fetal red cells. Where it is necessary to give additional doses of anti-D immunoglobulin as guided by tests for fetal-maternal hemorrhage, the dose calculation is traditionally based on 125 international units of anti-D immunoglobulin per milliliters of fetal or inadvertently transfused D-positive red cells for IM administration. There is some evidence from pharmacokinetic studies that high body mass index or BMI is associated with lower serum peak levels of anti-D immunoglobulin following intramuscular administration. The deltoid muscle is an appropriate and safe site for intramuscular administration of anti-D immunoglobulin. If the gluteal region is used, particular care should be taken to ensure that the injection is given into muscle, as absorption may be delayed if it only reaches the subcutaneous tissues. In women with severe thrombocytopenia, equivalent to a platelet count of less than 30 or equivalent to 30 multiplied by 10 to the 9 power per liters, or a history of a bleeding disorder such as severe von Willebrand disease, anti-D immunoglobulin should be administered IV or subcutaneously depending on whether a preparation suitable for IV use is available. Documentation and audit trail of the issue and administration of anti-D immunoglobulin. The European Union Guide on Good Manufacturing Practice recommends that there is clear documentation and record keeping to ensure traceability of all blood products, including anti-D immunoglobulin, from donors to recipients. Adequate records of issue and administration should be maintained to allow full traceability of anti-D immunoglobulin. Informed consent. All pregnant women must be offered written and verbal information about anti-D immunoglobulin to inform their decision about receiving anti-D immunoglobulin. Maternal consent must be obtained prior to giving anti-D immunoglobulin, and the woman's decision to either accept or decline the injection should be clearly recorded by the healthcare professional, both in the woman's handheld and hospital records. Assessment of the volume of fetal-maternal hemorrhage. This is required when a D-negative woman experiences a potentially sensitizing event after 20 weeks gestation and after the birth of a D-positive baby to determine whether the standard dose of anti-D immunoglobulin administered has been sufficient to remove all fetal red cells from the maternal circulation. Where the fetal-maternal hemorrhage result shows that insufficient anti-D immunoglobulin has been given to cover the bleed volume, an additional dose of anti-D immunoglobulin should be administered within 72 hours of the sensitizing event. The additional dose of anti-D immunoglobulin should be calculated as 125 international units for every 1 milliliter of fetal red cells, and should take into account any postnatal anti-D immunoglobulin dose if already given, but not any dose given as routine antenatal anti-D prophylaxis. A follow-up fetal-maternal hemorrhage sample should be tested after 72 hours if the additional anti-D immunoglobulin is given intramuscularly, or after 48 hours if given intravenously, to check for clearance of fetal cells. Further dose or doses of anti-D immunoglobulin and continued follow-up will be necessary if fetal cells remain detectable. A fetal-maternal hemorrhage confirmed by flow cytometry as greater than or equal to 4 milliliters is considered to be significant, and even if such a bleed is covered by the standard anti-D dose administered, a follow-up fetal-maternal hemorrhage sample is still required to confirm that anti-D immunoglobulin has been administered and to check for clearance of fetal cells. The presence of free anti-D in maternal plasma does not necessarily indicate adequate prophylaxis, and additional doses of anti-D immunoglobulin should be continued until D-positive red cells are no longer detectable. Anti-D detectable in samples from pregnant D-negative women. Antibody screens on maternal pre-transfusion samples may be positive following injection of anti-D immunoglobulin. Detectable anti-D may be passive or immune, and there is no serological method for distinguishing between the two. It is important, therefore, that regardless of any prior administration of anti-D immunoglobulin, any anti-D detected at 28 weeks should be quantified and the results made available in the woman's handheld and hospital records. Where anti-D is detected in a sample from a pregnant woman, further history should be obtained and investigations undertaken to establish whether this is immune or passive. If no clear conclusion can be reached as to the origin of anti-D, then prophylaxis should continue to be administered in accordance with guidelines for D-negative women who have not formed immune anti-D. Appendix number 2. SHOT or Serious Hazards of Transfusion flowchart to guide the appropriate administration of anti-D immunoglobulin.